Hi, welcome to tonight's webinar on hepatitis C. Tonight we're lucky enough to have Professor Ed Gane joining us. Thanks for coming, Ed.
Pleasure, Di.
So tonight is hepatitis C treatment. Why GPs should do it. We're moving, this is a call to action, I think, Ed.
Absolutely, absolutely. So I think why GPs should do it, well, as you'll see, it's something which is extremely rewarding, and this is a disease which can be eliminated from New Zealand, certainly within the next 15 to 20 years, but it needs your buy-in to this to achieve that. So we're going to start off with a 101 in hepatitis C, and first of all, just who is at risk? Who should we test for hepatitis C in practice? This is a virus which is spread blood-to-blood transmission. So the historical association was, of course, with blood transfusion before 1992, but that's no longer a risk factor in New Zealand as the look back has picked up all of those. We still see occasional people coming in from overseas who have had health care or blood transfusions prior to introduction of screening in those countries. By far the most important risk factor is a previous injecting drug use, and this accounts for probably 95% plus of new hepatitis C infections in this country, as it does in Australia and most Western countries. The peak age of infection is actually in the late teens, early 20s, and that's important because if we diagnose somebody in their 40s, it means that they've already had the infection for 20 to 30 years and could already have advanced liver disease or cirrhosis. There was a peak incidence in New Zealand of between really from the 1970s, 80s and 90s, but we still have a reasonably high incidence of probably around 1,000 to 1,200 new infections every year still, and this has been partly fueled by the methamphetamine epidemic we're now dealing with. So ongoing infection is an issue, and this is an issue we'll come to with looking at how you should screen your patient population. Tattooing and body piercing is a risk, but that really is only a risk where people are using unsterile equipment, in particular in prisons. It is a well-known route of transmission in prison. We think about 1.2% of the population is infected, so that's about 50,000 people. And that's the same in Kaitaia and Bluff. So in most practices, it's going to be about 1.2% of your patient population will have chronic hepatitis C. We think still around 40% remain undiagnosed. So there's a real need to get out there and find those patients. A couple of things. There is a risk of mother-to-child transmission because, as I mentioned, most people get infected in their teens and early 20s. They're obviously childbearing potential. About a third of people are women. So it is important in women who are found to have hepatitis C later in life that you do discuss with them the risk for their children having hepatitis C, and that infection occurs at the time of birth. There's no difference between cesarean or natural delivery. It's the same risk of around 5% or 1 in 20. And we would recommend testing all children of women who have hepatitis C. Sexual transmission is really rare with hepatitis C, so it's not like hepatitis B or HIV. And sexual transmission is usually related to certain risk factors, MSM, HIV positive men and women, traumatic sex during menstruation or genital ulceration are all associated with hepatitis C transmission, but otherwise there's actually no risk for barrier contraception.
Just a little bit alarmed. What is MSM for the...
Men who have sex with men, and that's certainly a risk with or without HIV infection. And there's been a little epidemic of hepatitis C in most major cities in the Western world. We've certainly seen a spike in numbers of acute hepatitis C. These are men who come in jaundiced, and these are often HIV positive men who are no longer using barrier contraception and are spreading hepatitis C. So most of the acute hep Cs we currently see are in this population. Okay, so what are the questions you should think of when you're thinking about who should be tested? These are the 7 questions the patients should consider, and this should obviously be spread through posters or whatever other media we can. The top risk factor is any history of injecting drugs in youth, and it could be 30, 40 years ago. Any blood transfusions prior to 1992, but that's largely historical now. Anyone who's ever been in prison should be tested for hepatitis C. Anyone who's ever been jaundiced or who has been told that they have abnormal liver function tests.
I'm feeling alarmed, Ed. I would say probably 40% of my population have abnormal liver function tests with this ever-increasing girth of New Zealanders.
Yes, yeah. Sure, fatty liver is such a common cause of abnormal liver function tests. With hepatitis C, it's about 90% of people who are infected with hepatitis C will have a persistently elevated ALT or AST. So that's a clue, but even if somebody has completely normal liver function tests, if they have any of these other risk factors, they should still be tested for hepatitis C, because around 10% will have normal liver function tests. The other risk factors are shown here: people who have been lived in or received health care, and certainly in the Indian subcontinent, parts of Southeast Asia, the Middle East or Eastern Europe, where they have really very high rates of hepatitis C, between 3 and 10% of the population. If you live in a household where someone else has hepatitis C, that's also a recognised risk factor, and you should be tested. As I mentioned, people who have received tattoos or body piercing using unsterile equipment, particularly in our prisons. How to test? Well, it's a very simple algorithm here. A simple test which can get done at any private laboratory, community laboratory, is the antibody test. This is relatively cheap, around $10, and it indicates exposure to the virus. So it doesn't tell you whether that patient still has hepatitis C infection or whether they may have cleared it, either spontaneously or with treatment. But the antibody test is the first line screening test because of the low cost. And somebody who's antibody positive, the infection should be confirmed by a hepatitis C RNA test. This is more expensive. It's somewhere between $100 and $200, but it indicates active infection. The third test is a genotyping test, and that tells you what strain the person has. And this is important because currently that's the result which determines eligibility for the new all-oral treatments. Currently, the government only funds all oral treatment for people with genotype 1. In some parts of the country, you only need to do a simple blood test, and this has been set up through Arlo Upton at lab tests here in the Greater Auckland region. If you send in the blood test saying targeted testing for hepatitis C, well, lab tests will test for antibody, and if that's positive, they will send that same sample to the reference laboratory, Lab Plus, who will do an RNA test, and if that's positive, they will do the genotyping test. So the next time you see the patient, you'll know not only do they have hepatitis C, but whether they are eligible for the currently funded oral treatment. We're trying to roll this out around New Zealand, but I'm not sure whether it's available outside the Greater Auckland region.
So we actually just state, please, targeted testing for HCV
Yes.
hepatitis C.
Yes, and they'll do all 3 tests for you.
Fantastic.
So the question which was asked is, how should I test my patients in general practice? Now, I've shown you the 7 key questions, and that will pick up everyone, and people don't have to. There's certainly still an amount of stigmatization associated with self-reporting previous injecting drug use. And we give a whole series of questions, and people don't have to say, I've got this risk factor. They just have to read the post and say, I want to be tested for hepatitis C. And what's the best way to approach that? Is it to have posters? Perhaps you could have a poster in your waiting room. It's been talked about in certain countries of doing burst cohort screening, where it's mandatory to test everyone born in a certain era. In the US, they relate that to the Woodstock era, the Vietnam War era, where they had a huge increase in heroin use, and that was by far the highest rate of hepatitis C in that country. The public health people in Australia at the Kirby have looked at the epidemics in Australia and New Zealand and feel that that approach would not work in our countries because whilst in America the epidemic was really peaked at around 2 decades, in Australia and New Zealand it's been going on for about 5 decades, and really if you're going to do that you should be testing everyone. Targeted testing, however, is the most efficient way to actually test for hepatitis C at this time.
Do you think there's any place for us writing a query and identifying all patients who have an abnormal ALT and AST and inviting them in to do further testing?
I think that's a great idea, Di. I think you'll pick up a lot of the undiagnosed. The other issue, I think, and talking about query builds, is going back, if you can, on your patient management system and pick up everyone who's been tested in the past, because a lot of people were tested 10, 15 years ago when there weren't effective treatments and they haven't engaged in follow-up or any further discussion about the hepatitis C.
That's an interesting point. So when we are doing the testing now, we're getting more information. Does someone change the genotype that they have, or does it, once we've got that information, is that where they are for life? Do we need to retest? I think,
yeah, going back, I said you should retest genotype if it hasn't been done within the last 5 years. And the only reason for that is where treatment, as I mentioned, is limited to genotype 1, which is about 60% of our patients. It is the main genotype. But the earlier assays we used to genotype patients sometimes made a mistake between genotype 1 and another genotype. So I think if somebody hasn't had a recent genotyping, that is not within the last 5 years, then that test should be repeated. But the genotype doesn't change, it's just the quality of the testing has.
So that's interesting. So just wrapping this up, we are going for targeted opportunistic screening here, but you know, you can do some query builds around liver function tests, particularly ALT, AST elevations, and we could also be screening for people who've been diagnosed with Hep C in the past and re-looking at those cases.
Right. Okay. I was asked to comment on treating acute Hep C. I don't think this is going to be a common problem for you to see. I mentioned there are about 1,000 new infections a year with hepatitis C. Acute hepatitis C is when people present feeling unwell with jaundice. That's actually uncommon with hepatitis C in adults. Only around 5 to 10% of people who get infected with hepatitis C will present with acute hepatitis. In most people, this is an asymptomatic or subclinical infection. But of those people who do present with acute hepatitis C and who are picked up, these are the risk factors. Over the last 5 years, we've only seen around 64 cases at our own clinic here in central Auckland. And in fact, although injecting drug use has been historically the major cause of acute Hep C, you can see that the second most common cause, which is the most common we see nowadays, is MSM, sexual transmission in gay men. Acute hepatitis C is as I said, it's not that common, and often people clear the infection themselves. And overall, around half the people who present with jaundice will get rid of the infection themselves because the jaundice is due to a very strong immune response. So we don't suggest you treat them immediately. Wait 8 weeks and check the hepatitis C status again. And about half of them would have cleared the infection. They still need counselling about the risk factors for transmission, in particular if they are injecting drugs, the risks of that and the need to try and engage with a rehab program. If patients remain positive and they have what we call persistent infection, and if they're chaotic, you probably don't need to treat them at that time because the cure rate's the same whether you treat them with acute Hep C or if you wait a few months and treat them for chronic Hep C. So there's no rush, but if they do want to be treated, if they're motivated and have a stable support network, then the treatments are very successful with between 90 and 100% cure. So acute Hep C, it's a cause for jaundice in general practice. It is a rare, if you can compare it to hepatitis B or other causes of acute hepatitis, it's a rare cause for acute hepatitis, but it's something which can be treated if somebody wants to be treated. I mentioned that. And yeah. Okay, what about chronic hepatitis C, which is, of course, most of the patients we have in the community. Most patients we see have chronic hepatitis C. And there certainly are reasons why we want to treat them. It may be in many patients an asymptomatic infection, but it has severe consequences if left untreated. Can I have that glass of water? Yep. I mentioned that most people get infected in their late teens, early 20s when they start experimenting with injecting drugs. But by the time they're diagnosed, currently most people are in their 40s and 50s. And by that stage, they've been infected for around 20 to 30 years. And a lot of them already have severe liver disease. And this is data from the ministry's Hep C pilot program performed in Wellington in the Bay of Plenty a few years ago. And they found almost 1,000 newly diagnosed people. The most common age was between 40 and 55. So they'd already been infected for 20 to 30 years. And as you can see, almost a quarter of them already had severe liver disease, what we call severe fibrosis or cirrhosis. And these are the people who are going to die from their hepatitis C. Left untreated, most people with cirrhosis will develop complications over time. Hepatitis C now is a leading cause of liver transplantation in New Zealand, as it is in most countries. And it's also the leading cause of liver cancer in New Zealand, with rates increasing 20% every year. Last year, we saw over 100 new cases of liver cancer due to hepatitis C. And this is devastating because the median survival after diagnosis is still less than 12 months. So this is becoming an increasing cause of mortality in this country. And really, it does reduce the life expectancy of your patients. This is a study performed in New York City. This is in people without hepatitis C compared to people with hepatitis C. And you can see that having chronic hepatitis C infection reduces your life expectancy by 18 years. So that's a significant impact on life expectancy, with 2/3 of people with hepatitis C dying before the age of 65. Hepatitis C doesn't just damage the liver, it damages many organs in your body. And I've shown them all here. You can see almost every organ system can be affected by the hepatitis C. And it does this because it's a viral infection in the blood. It infiltrates all these organs and it causes an inflammatory reaction or an immune-mediated response and damage of these organs. So many patients may complain of symptoms completely unrelated to their liver. If we look at this, these are two real patients I'm going to show you now who have non-liver consequences from their hepatitis C. The first is a woman who I saw a couple of years ago who presented with a rash in her legs after she'd been skiing. And she'd been feeling unwell for some years. She had a significant alcohol intake, and on examination she had some signs of liver disease. She also had this really vasculitic skin rash on her legs, which you can see here, really a particular rash. Nowhere else, just her legs. Her blood test, as you can see, showed that she had a low platelet count and a low neutrophil count, and this suggests that she has advanced liver disease. This is due to a large spleen. She also had a high rheumatoid factor, which is a direct complication of hepatitis C. She had hepatitis C infection and she was infected with a type called genotype 1b. On inquiry, she did admit a previous risk factor for hepatitis C exposure through injecting drug use in her 20s. By far the most common risk factor we find in all our patients. She was referred for a FibroScan by her general practitioner, and that showed that she had a very high score. A score of over 12 usually means that the person already has cirrhosis. And she had a test for cryoglobulins, and this little picture is actually her serum, which we took off and cooled down to 4 degrees, and this precipitate is cryoglobulins, which are the virus binding to rheumatoid factor in the blood. So the rheumatoid factor is stimulated by the virus, and it's this cryoglobulins which causes skin rash. So she was treated. She was treated with the currently funded all-oral treatment. Because she had this subtype, she didn't need the ribavirin, I'll explain it. And the rash disappeared within a couple of weeks, and it's never come back, and she's now cured. So now that she's cured, her cryoglobulins have disappeared, her skin rash has disappeared. And this is not an uncommon presentation of hepatitis C in colder climates. My colleagues at Christchurch see a lot more than I see now in Auckland. I used to see a lot in London, but it's relatively common in the winter months. Right, oops. So she will stay in, this woman was referred to clinic because she had cirrhosis, and she'll stay in the hospital clinic for follow-up because she has cirrhosis and is at risk for long-term complications. And those complications I mentioned are the liver cancer, but also she can get varicose veins in her gullet or varices. The second and much more common presentation in general practice is that of lethargy and fatigue. This is an almost universal symptom of hepatitis C, and we now know that it's clearly related to the virus. This is a man in his 30s. It doesn't matter what age you are, you can get severe lethargy. It doesn't matter how severe your liver disease is. This is a direct response to the virus in the blood. He had hepatitis C. His risk factor was that he was in a rock band. It should be in the 90s. And in fact, one of the band members had already been a patient of mine and had died of liver cancer a couple of years earlier. So this person knew that he was at risk for hepatitis C through injecting drug use. Remarkably, he had a normal FibroScan with no evidence of fibrosis. So a score of less than 5 is normal. A score of more than 12 is cirrhosis. So in between is a gradation of fibrosis.
Let's just pause here for a second and talk about this FibroScan. How does a GP order a FibroScan, and where do they go to get that?
They order it through an e-referral. Certainly many district health boards now, you can, if you have an e-referral mechanism for gastroenterology, you can order a FibroScan on that portal. There will be a tab for FibroScanning. That will come through to our department. We will grade it. The waiting time for FibroScans is only 2 to 3 weeks currently. And our nurses who do all the FibroScans will triage that patient, call the patient in, do the procedure, send back the result with an interpretation, that is whether the patient has no scarring, a lot of scarring or cirrhosis. We'll send that back to the general practitioner. There's no need for that patient to see a specialist to come to clinic. They will simply go in for the FibroScan appointment, which takes 5 to 10 minutes, and then that result will be sent back to the GP. And I'll show you the e-referral form in just a moment.
So it goes to gastroenterology. It doesn't go to radiology.
No. So there are about 16 FibroScan machines now scattered throughout the country, and not every district health board has one in their department, but they certainly will have one in the district they can refer to.
How often do you need to do that FibroScan?
Well, you need to do it once, and then hopefully that person will go into treatment. We would say that if somebody is not being treated, you should repeat it every 3 years. Once somebody has been treated, you don't need to do it again. It won't progress.
If they'd had one 3 years ago?
3 years ago, I think I'd, if it was a good quality FibroScan, I think 3 to 4 years, I'd be happy with that. Yep.
Do you need to do a liver ultrasound scan at all?
Only in people with cirrhosis, because it's the people with cirrhosis who are at risk for liver cancer, and those people need to have regular FibroScans. In most parts of the country, it's not possible for GPs to order surveillance ultrasounds. So this is the only reason why people with cirrhosis are currently being referred back through to the hospital system. I can skip through it.
Does a cirrhosis resolve once someone is treated?
Actually, the liver is a very dynamic organ, and it's turning over collagen, scar tissue, all the time. So if you can eradicate hepatitis C and the inflammation goes from the liver, then the cirrhosis may actually reverse. The important thing to note is that the person's risk for liver cancer doesn't go away completely. We think it falls by about 50% after a year, but that person who's had cirrhosis documented prior to treatment, even though they're no longer cirrhotic 2 or 3 years later, they need to carry on having ultrasounds as surveillance for liver cancer. On the plus side, once they've been cured and the liver scarring regresses, they are at no risk for developing liver failure in the future.
So this young guy's done very well.
And his lethargy disappeared. And in fact, the remarkable thing about using these oral treatments is that as soon as the virus becomes undetectable in the blood, which is 2 to 3 weeks after you start the treatment, patients feel better. Their fatigue disappears completely. And many placebo-controlled trials have shown that this is directly related to the suppression of the virus. And provided the person is cured, their fatigue disappears. Okay. So, and this person doesn't have cirrhosis, so this person can be reassured and needs no follow-up regarding their liver disease. Okay. Just a couple of slides to show you that cure is associated with improvements in quality of life on the left and improvements in fatigue score. That means less fatigue, 100% being normal matched population. And many, many studies have shown now that the fatigue disappears early on in treatment and doesn't come back. And this now is regarded as an indication to treat in patients who have no significant liver damage. Now, perhaps the most important part of the talk is how do you use VIEKIRA in your practice? And that's something we really want you to feel comfortable with. The bottom line is all patients infected with genotype 1, and I'll come to other genotypes at the end of the talk because that's also important, should be treated by their GPs unless they have cirrhosis or they have other complicating factors which make the treatment very, how shall I say, can be problematic to use. So if patients have HIV co-infection or on particular treatment for that, or if they have complex neurological or cardiac conditions, then we should really treat them in the hospital because we may have to take special precautions with them. But patients who are otherwise relatively uncomplicated, who don't have cirrhosis, should certainly be treated by their general practitioners whenever possible.
And the HCV G1 accounts for about 60%?
About 60%, yeah. So this is a simple algorithm. Somebody who has risk factors can get testing, and this is the reflex testing we talked about, or if you don't have that available, that you just have to repeat them. If the tests come back positive for antibody, you do the RNA test and then the genotype test.
Should you do hepatitis B testing at the same time?
I think it depends on the population. Hepatitis B in this country is very much linked to certain ethnic groups. As you know, New Zealand Māori, Pacific Island and Asians have a much, much higher rate of hepatitis B than Europeans. They have rates of between 6 and 10%, whilst Europeans it's less than 1%. So I wouldn't, I think it's a simple test to do in somebody who's born before vaccination. Possibly should be done before you start treatment, but the people at highest risk are those 3 ethnic groups. Fibre scanning e-referrals, if they don't have cirrhosis, you should keep them in primary care and treat them there. If they're genotype 1 and you treat them, they have a 95 to 98% cure rate. And that's supported by a lot of real-world data now, people being treated in the community. The relapse rate's really, really low, and if they do relapse, then we do have rescue therapies, which should be around, I hope, by the end of this year. But that's only 2% really overall. People with genotypes 2 and 6, we'll come and talk about that in a minute. But we hope to have treatments for those people certainly within the next 6 to 12 months as well. There are a heap of resources available for you to help you, the practice nurses and the doctors, treat people in the community. We have the Hep C e-learning. This was first written back around 7 years ago. We updated that last year with the help of PHARMAC and the Ministry of Health to include the all-oral treatments for genotype 1. And you do get CME points for this, both for the practice nurses and GPs. A more popular resource has been the BPAC resource, and this has been hugely popular, over 6,500 downloads since we finished this in October last year. And this has the same information as the e-learning or the other resources. It's just in a hard copy way you can print out. And you've got the health pathways. These are the Auckland health pathways. You also have it on the Bay of Plenty health pathways, the Canterbury health pathways. Most of them have a step-by-step how to treat hepatitis C in general practice. Okay, this is, if we just concentrate on cure rates, Overall, genotype 1b is a type of genotype 1. There are two types, 1a and 1b. 1a is 3/4 of our patients, 1b is 1/4 of our patients. It's important to know the difference because the 1b's are easier to treat, but you can see almost every 1b patient will be cured, whilst it's 96%, which ain't bad compared to the old interferons when it was 10 to 20%. So this is 12 weeks of treatment. 12 weeks of tablets will cure overall around 98% of all our patients. And this is what it looks like. So it comes in a little box for each day, dispensed by the local pharmacy, and there are around 250 accredited pharmacies for dispensing VIEKIRA PAC.
That's quite important. There are actually pharmacies who've had extra training,
yes,
to support patients in
indeed,
the management
indeed.
of Hep C. And so they are actually accredited for this. So you need to find out who's accredited near you.
And that's available on when you apply through the forms. This is what it looks like each day. This is the morning, you take 3 tablets, evening you take 1 tablet. If you're genotype 1A, you take ribavirin as well. Ribavirin comes in a little bottle, and you can take either 2 and 3 or 3 and 3, depending on the weight of the patient. So this is genotype 1A. You need to take the VIEKIRA PAC plus the ribavirin. The easier to treat 1B, you only need the VIEKIRA PAC. You don't need to take any ribavirin. It's important to remember that because occasionally we've seen patients who have inadvertently got ribavirin when they haven't needed to, or more importantly, haven't got ribavirin when they needed to. And in genotype 1A, shown here on the left, that compares VIEKIRA with ribavirin to VIEKIRA PAC without, and you can see that ribavirin increases the cure rate by almost 10%. So for 1As, remember to prescribe the ribavirin. The 1Bs do not need ribavirin. Almost everyone's cured without ribavirin. This is a PHARMAC request form you use, and that's downloadable, as you can see, with the address on the bottom to send off, and they will let you know where the closest pharmacies are which can dispense the drug for you. And as Di said, they are trained to discuss the treatment with the patient. They'll also check to make sure there's no drug-drug interactions with the patient's other current medications. Right. This is what the FibroScan machine looks like. This is our big FibroScan machine, and we've done around, well, many, I think 15,000 FibroScans. So this is quite an old machine. This little thing down here, about the size of an iPad on the screen, that's a new portable FibroScan machine, and it weighs just 3 or 4 kilos. And our nurses now do outreach FibroScan clinics, places like the City Mission Quarter Centre. They go to the prisons, they go to opioid substitution centres, and so they take this in the car to various places. And if general practices have a few patients, they're happy to take it to a large practice to do FibroScans at the practice. Otherwise, the patients come in to our room and get a FibroScan on this larger machine.
There's been an interesting note here by Jo Delazille, and she's just pointing out that for Midland DHB, that is the Waikato, Lakes, Taranaki, Tarawhiti and Bay of Plenty, you can refer to the Midland Community Hepatitis C service for education and FibroScans via your BPAC e-referral.
Yes.
So there's
so those 2 regions, there are 4 regions, Midlands and Central. The Hepatitis Foundation are providing the community FibroScanning service, and that's correct. So they go through the Hepatitis Foundation nurses who will organise that for them. In southern, Christchurch and Dunedin and Invercargill, and the northern regions, the patients that's provided by the hospitals.
But it is exciting to hear that you're going out to the prisons and to places with to target.
I mean, we've been delighted with the buy-in. We've also now opened a clinic at the Needle Exchange in Karangahape Road, East Street, and we're using that as a healthy liver clinic. So people are coming in, asking for a FibroScan, and our nurse will talk to them about being tested for hepatitis C, and we're setting up a point-of-care testing service there.
Fantastic.
So this is the e-referrals form. I'm not sure if Graham's on the line. Graham, I've stolen one of your referrals. And this, we're seeing more and more referrals now from GPs in our region who are just asking for a FibroScan. I'm not referring the patient through to be counselled on their hepatitis C. They're doing it all themselves. All they want from us is a FibroScan. So we get this referrals, and it comes out something like this on the FibroScanning portals. We triage those. It's a 2 to 3 week wait only for that, and then the result will go back to the GP with whether or not the person has cirrhosis or not.
Interestingly, I know we'll maybe finish this first, and I'm just taking you back to the use of this product, the VIEKIRA.
Yep.
Is there any contraindications to using it that we need to know about in terms of age or anything specifically in this group that we need to think about?
There's been a ton of data now showing that age is no longer required. No, age is no longer a contraindication to treatment. And you can say, well, what if the person is aged 95 and is otherwise fit and well? Well, you can say they're not going to get any survival benefit from it, but they may feel better. So their age is not a cutoff, and the response rates are exactly the same whether somebody's aged 90 or 10. The response rates are exactly the same. There are some contraindications, and the most important contraindications are people who really have severe liver disease, who have already decompensated, and those people shouldn't be treated in the community anyway. And for those people, there's an alternative treatment once they get that sick. It's called Harvoni, and that's only available for people who have liver failure. And these people are usually either being considered for liver transplant or have contraindications to liver transplant. Other reasons why you cannot treat somebody is if somebody is pregnant or is breastfeeding. And this is largely because the ribavirin is teratogenic and will come to the need for contraception in women of childbearing potential in a minute. There are a few other contraindications, and these mainly revolve around possible drug-drug interactions with their other medications.
And we're going to come to that soon.
Yeah. Okay. So if you don't have a FibroScanning available, there's a simple blood test you can do called the APRI. And this means just measuring the serum AST and the liver function test and measuring the platelets and the full blood count. And then you can work out what we call the APRI ratio, and that's downloadable from this free website. And if the APRI is less than 1, it means that they don't have cirrhosis and they can be treated in primary care. So that's the alternative to FibroScanning. Monitoring is very simple for these all-oral treatments. This isn't like the interferon of yesteryear. Monitoring, if they are on ribavirin, you have to test people for hemolysis, and that's at week 2 and week 4 and week 8. If they are not on ribavirin, they need no monitoring during treatment. So it's very simple.
Oh, I'm sorry.
Oh, no. I got you. Okay. We talked about the issues with ribavirin. It does cause anemia because it causes a dose-related hemolysis. This is reversible, and it's purely because the ribavirin drug sits in the red cell membrane. So that's why you monitor hemoglobin in people receiving ribavirin, and you measure it at week 2, week 4, and week 8. In people who have kidney disease or have severe heart disease, you have to be cautious because they can get more anemic, and they can get obviously angina if they have severe ischemic heart disease. It's important to know not everyone gets anemic, and only around 8% of people require a ribavirin dose reduction. That means 92% people stay on the dose of ribavirin they started with. And it doesn't matter if you reduce or stop the ribavirin, the cure rate is just the same. Now, drug-drug interactions, I'm not going to go through drugs in detail here, just to say certain drugs interact with VIEKIRA because VIEKIRA contains ritonavir, which is a potent inhibitor of many drug metabolic pathways. There's a very simple and very friendly online app, and this comes from the University of Liverpool website, and it's freely downloadable, and it can be on your smartphone, it can be on your desktop, and it's really, like I say, it's fun to use. You just put in you click on VIEKIRA, you click on the drugs the person's taking, and it will come up in either green, which means no drug interaction, orange, which means potential interaction, or red, which means that you cannot use them together. There's also a function on this website. If somebody is on a particular drug, you can click on the class and it will tell you what alternative drugs you can switch to and still receive the VIEKIRA pack.
What about the New Zealand formulary? Has it got a good section on this?
It has, yes, it has. So there are some other resources available. The New Zealand formulary. You've also got AbbVie have a large resource which is easily either downloadable or accessible, and they have, I think, an 0800 helpline which you can phone during working hours 5 days a week. But as I mentioned, the pharmacists are particularly trained in handling drug-drug interactions, so it's really nice for the pharmacist who will meet the patient at the time the drug is dispensed to go over all the concomitant meds which the pharmacist may already have access to, and say which drugs may be of particular issue and let the general practitioner know. This just gives you an idea of some drugs. St. John's wort is a red drug, but you can see many drugs such as citalopram are quite safe to use. We talk here about progesterone-only pills are fine. Ethinyl estradiol cannot be used. I think we come to that. So we come to that later. Women of childbearing potential, because of the teratogenic effects of ribavirin, they should use reliable contraception, but they should not use an oral contraceptive containing ethinyl estradiol because of a significant drug interaction with VIEKIRA pack. Yep.
Is it okay to be using Jadels and other progesterone-only products, Pibrentisvir?
Progesterone-only products are perfectly safe. It's just the ethinyl estradiol. Okay, so what's happened to my practice? I'm doing myself out of a job, and I'm not too unhappy about that. This is what happened when we started, when VIEKIRA pack was first funded last year, and initially the first 3 months it was only funded for hospitals to dispense, so to specialists only. You can see that we were treating patients, including a lot of patients who didn't have cirrhosis. That's changed now. Almost everyone we treat in the hospital system has cirrhosis, or they have other complicating issues such as the colours of HIV infection, that should be blue, or psychiatric psychotropic medications which have significant drug-drug interactions. We've asked our patients, because we had warehoused a lot of patients were waiting to be treated, waiting for all oral therapy. And we had over 100 in our books, and we went through systematically and asked all the patients whether they wanted to be treated in clinic, or if they were non-cirrhotic, whether they wanted to go back to their general practitioner. And almost everyone said, could we please make contact with their general practitioner? And I must say, I have been delighted with the response we've had from primary care and certainly in our DHB, and that the GPs have really taken on this challenge and have taken on learning and treating patients in their practice. When we've told them who needs to be treated, they've taken them on board. And we think this is really important for trying to encourage targeted testing. If GPs know about patients with hepatitis C and are treating them and are curing them, I think it does increase awareness and increases the enthusiasm for testing people in your practice.
One of the exciting things, just stopping at that place, is that the response from patients is so incredibly positive. I've had one patient who has been treated, and having had this hanging over his head for 20 years, the joy of being treated and now, free of disease has been one of the most rewarding treatments I've been involved in the last few years.
I think the uptake has been sensational. Up until VIEKIRA pack was funded in July last year, the numbers of people being treated each year was actually on the decline, and the number of people who received PHARMAC funded treatment in the preceding 12 months was under 200. In the first 9 months since VIEKIRA pack has been funded, just under 2,000 people have started treatment. That's an increase in treatment uptake more than 20-fold. And in certain parts of the country, such as ADHB, Northland and Bay of Plenty, most of the patients starting on treatment are being started by their general practitioners. It's the minority now who are being referred to hospital for treatment.
It's interesting talking to GPs and nurses and pharmacists about this issue. They're using different models to treat. So some practices are actually getting one GP to subspecialise in hepatitis C and to have a nurse who is subspecialised. The other one that I've seen quite clearly is bigger practices having very, very clear protocols so that there is a pathway that they can work through within the practice.
I think that's right, Di. But if it's, you know, the numbers of people you're likely to have in an average practice are only going to be about 3 or 4 patients. And most practices will certainly have 1 or 2. There are some larger practices who look after certain demographics where they have many more patients. I mentioned we've got an outreach clinic in the Calder Centre up at the City Mission, and they have well over 100 patients, and they have started over 20 patients already on VIEKIRA PAC. And they run it there. 2 of the GPs there have trained in this, and they have a nurse who has a particular interest. But I should say that the specialist nurses in the hospitals are very, very keen to give whatever support they can to the practice nurse to help them with any questions, to get people on treatment and maintain them on treatment.
Before we move on, I just want to close this section down because this is really the GP-centric part. I would actually encourage practices to sit down after hearing this talk and to say, how do we want to implement it in our practice, taking on the unique aspects of their practice, not just the practice population and the burden that they're going to carry or not carry, but also on the size of the practice, their nurse to doctor ratios and things. So to sit back and to plan this out in a very efficient way for your practice, I believe, is well worth the time.
For sure, for sure. The question which a few people have typed in is what to do if people are infected with other genotypes. Now, we said around 60% of people, of the 50,000 New Zealanders with Hep C, have genotype 1. That means around 20,000 are infected with other genotypes and have no access to the all-oral therapies. There is pegylated interferon and ribavirin available for these patients, but it's hard work. It's 24 or 48 weeks of treatment, and the cure rates are still rather low. So what to do with these patients? This is just such a patient, and we're still seeing these patients being referred in by general practitioners who can't treat them at the moment. So what treatments are available for these patients? Well, I've mentioned there's pegylated interferon plus ribavirin, but in fact most patients are declining, and I think that's not unreasonable. We do expect to have what we call pan-genotypic treatments available within a few months. So this just tells you, well, I mentioned that.
I think it's a good one to show me.
Okay, this looks at the various genotypes. This is a large cohort of patients genotyped at the local reference laboratory, over 6,000. You can see that the next most common genotype is genotype 3. Here, 35% of our patients are genotype 3. And a smaller proportion of genotype 2. And we have a few genotype 4s and 6s. So genotype 6s are particularly common in Hamilton and Auckland, and it reflects a very large immigrant population from Indochina, especially Cambodia and Laos, but also from Myanmar, where genotype 6 is a predominant genotype.
Can you have more than one genotype?
You can, but usually one will dominate and the other will disappear. The population who were often infected with more than one genotype were those who had been infected through contaminated clotting factors, the haemophilia population. Thankfully, this is a population in whom hepatitis C has already been largely eradicated because ACC funded treatment before PHARMAC did. So I'm pleased to say that hepatitis C is no longer a major problem in our haemophilia population. And they had more than one genotype. Other than that, it's actually very rare.
One of our colleagues has asked about viral load. And, you know, we're looking at genotypes. Is there any way we can look at how intense the viral load is in the personal? Is that even important?
Viral load, forget it. It's no longer important. Viral load was really important with interferon because it determined chances of response, but it's of no relevance with these new treatments. And I would say once you've tested somebody and you know that they're hepatitis C RNA positive, the only other indication to test viral load is after they finish treatment, 12 weeks after they finish treatment, to show that they're cured. And most people will be cured, 98% will be cured, but otherwise viral load is no longer relevant. So what to do? Well, there are, you've heard there's been, especially those of you from the southern region, there's been a lot of publicity about importing, self-importing generic drugs. And this is now, this is certainly legal in New Zealand and Australia. You can import up to 12-week supply, and it costs between $2,000 and $2,500 for the new generic combinations. These are from drugs which are made under license from the big US manufacturers, usually in India. The HCV Buyers Club has been the main portal for New Zealanders, and you can see almost 500 New Zealanders have already accessed HCV Buyers Club. The cure rates are the same as they are for the branded drugs. So these are very good drugs, but they do cost the patients between $2,000 and $2,500. There's on all the resources I showed you, there's a step-by-step process of how the patient can get their generics and import them. But they do need a prescription either from their general practitioner or from a specialist. I think this is second best, okay? For patients to have to go through this, it's quite time intensive, and it takes 3 or 4 weeks for the drugs to arrive, and it costs them $2,000 to $2,500. And most of my hepatitis C patients cannot afford that. What's coming is much, much better. And what's coming, I'll just skip over this, what's coming are the new pan-genotypic drugs. And these are, the first one is called Pibrentisvir. This is already approved by MedSay. Overall, this has a cure rate of 98%, no matter what genotype you have, 1 tablet a day for 12 weeks. So this is the next generation beyond VIEKIRA. The second one is this combination, Glecaprevir, Pibrentisvir. Again, it's a fixed dose combination. And here, if you look at the teal colors, only 8 weeks will cure almost 100% of patients without cirrhosis. And this is a drug which I think will revolutionize community prescribing for hepatitis C. You won't even need to check the genotype. You'll just have to do a fiber scan. If somebody doesn't have cirrhosis, you can give them 1 tablet a day, it's once a day medicine for 8 weeks, and almost everybody will be cured. I think either of these two treatments are probably 6 to 12 months away, and PHARMAC is currently looking at both of them. So when that comes through, I think you're going to find it's going to be very, very easy to convince people to come in and start treatment, and it's very, very simple for you. Both of these new pan-genotypic treatments have no side effects. Now I mean no side effects, and they have no significant drug-drug interaction. So much, much easier to use.
It's very exciting, isn't it, that there is these advances. One of the issues is that PHARMAC will have to go through its funding criteria and whether it does approve these drugs for funding.
Yeah.
I'm kind of interested. We've got a treatment now available for genotypes 1A and 1B.
Yep.
The second group, should we be, I know we have to import the drugs. I'm going back to the present. I want to know 2 things. What is the risk of delaying treatment with that group of genotypes 2 to 6? What is the risk of delaying it for 12 months and saying, look, we'll put you on recall and bring you in 12 months?
Well, I think the fiber scan is very helpful. The fiber scan is very, and if the patient has severe fibrosis, I guess I'd be more supporting the patient looking at importing generics. If the patient has does not have severe fibrosis, has mild or even moderate fibrosis, I think they can wait for 1, 2 years, however long it takes, before these pan-genotypic treatments are funded. We don't know, you're right, we don't know when they're going to be funded. It may be 6, 12 months, it could be longer. Currently, the only funded treatment for these patients is interferon and ribavirin. Some patients may want to go down that track, but most of our patients are saying, we'll prefer to wait, thank you.
If we did import these drugs, is there any way we can go to understand them, the side effects of them, you know, the monitoring and all of these, or is it very similar to
the drugs which are being imported, the generic drugs, are easier to use. They are fixed dose combinations. That's 1 tablet a day for 12 weeks. Standard regimens. There's a slightly different regimen for genotype 1 from the other genotypes. Most people don't need ribavirin. The drug-drug interactions there are minimal. So they are relatively easy to use. Just say one word of warning. If your patient wants to go down the road of importing generics, it's important that they look carefully where they're importing them from. And I would strongly encourage people to use a recognised portal such as the HCV Buyers Club rather than import them independently from Bangladesh or China, where there has been a problem with inactive drugs, either counterfeit drugs containing no activity or diluted drugs. So I think if they are going to go down the road of importing generics, that they do it through a recognised portal such as that HCV Buyers Club portal in Tasmania.
Right.
Okay, so Hep C is curable. I think treatment in general practice is perfectly safe. I think you as the patient's doctor knows more about the medical and psychosocial background of the patients. You know what comments are on.
What about supplements? Because I have a lot of patients using supplements. Does that Liverpool interaction look at supplements as well?
I don't think it does. The supplement to be very wary of, St. John's wort has significant drug-drug interactions with a lot of drugs metabolized by the liver, so that's an absolute no-no. Most of the others are not known to have particular interactions with VIEKIRA, but I don't think that is on the Liverpool website.
Right.
And that's really just to say that we can eliminate Hep C. If we increase we've had a 20-fold increase in treatment uptake. If we continue at this route, we will be able to eliminate Hep C within the next 20 years. And this really is mooted to be the first infectious disease which will be eliminated globally after, of course, smallpox. So we need help from really you and the community if we are going to eliminate hepatitis C, but I think it's eminently possible within certainly the next 15 to 20 years.
We've just been, there is, AbbVie has a medical information line. If you are going to be prescribing, seeking advice from the pharmaceutical company about supplements is what one of our listeners has advised. What happens if you are on these tablets? I'm just going to ask some more general questions now.
Sure.
You've got group 1 genotype and you're treating them and they miss a tablet or they miss a couple of days of tablets. What do we do?
We tell them to go back and take the tablet at the next scheduled dose. Not to take double up, just to take. So if they miss one dose or 1 day dose, then they should take it the next morning, but they shouldn't double up. And missing 1 or 2 days won't matter. If somebody misses a week or 2, that may have a significant effect on outcome. Missing 1 dose or 1 day's dose itself won't have a dramatic effect on outcome.
Right. Just looking back and seeing if there's any more particular questions, but what I guess the big question we're getting through from people is around cirrhosis and knowing when to hand over for specialist care and when to be able to feel confident that you're going to treat in primary care.
Yeah, and just to reiterate, fibre scanning is by far the easiest way. It's obviously it's not invasive. It takes only a few minutes. It's very reliable for saying whether somebody has cirrhosis or not. And you should do it before you treat somebody, because the fibre scan is not accurate if you use it after somebody's been cured, because once the inflammation's gone away from the liver, the fibre scan reading becomes inaccurate. So you need to do that fibre scan and you need to do it before you start treatment.
The other thing that we've got is someone is suggesting that you could have psychosis side effects to this medication. Is there any concern about?
Certainly with the old interferon and ribavirin, these had significant psychiatric side effects. As you know, interferon causes depression, depletes the brain of serotonin, and it has been known to precipitate psychosis. You take away the interferon, you still have to use, in the genotype 1A patients, they use that tablet ribavirin. Ribavirin can have some effects on mood, although it's nothing like the old effects of interferon, and it tends to be very idiosyncratic. It's not a common compound. But you're right, some patients do complain of feeling very tired or just down during the ribavirin and feel much better once they stop it.
Someone has asked about the reactivation of hepatitis B when you're taking this treatment. Has that been an issue?
There was a bit of, I'll call it hysteria, came out of the US last year with a report of somebody who had reactivation of hepatitis B who had had previous exposure. This is somebody who had been infected as a child, had cleared the infection, and was what we call natural immunity. And in fact, that has not been shown to be the case. The other question is, what if somebody has co-infection, hepatitis B and hepatitis C? Can that reactivate the hepatitis B? It has been reported, but by far the biggest study ever done was presented at a meeting earlier this year from Taiwan, where the common, this co-infection is not uncommon. And they showed that over 100 patients who received treatment of their hep C, although they had mild increases in the hepatitis B DNA, no patient developed significant hepatitis. So if somebody has hepatitis B infection as well as hepatitis C infection, it's worth determining whether they need treatment of the hepatitis B for the usual criteria and starting them on hepatitis B treatment before you start them on hep C. But in most cases, they will not need treatment for their hep B. They'll have a low HBV DNA, and for those patients, I'll just go on and treat the hepatitis C. Great.
We've had some questions around cannabis and alcohol. So when we're treating patients with VIEKIRA and VIEKIRA PAC RBV, do we need to stop people drinking?
And this also pertains to people using other drugs. Any alcohol intake, to the extent where it may be interfering with compliance with their medication, would be a relative contraindication. I think somebody who's drinking so heavily that they are going to damage their liver from alcohol isn't really going to benefit from curing the hepatitis C. If somebody has a heavy alcohol intake, even if you cure their hep C, they'll almost certainly still progress to cirrhosis. So I think you need to address their alcohol abuse at the same time. But one thing I want to stress is
non-abuse.
And abuse.
Not about non-abuse. I mean,
there's no reason to stop drinking during treatment. It won't interfere with the effectiveness of this treatment. The other important thing is we are really trying to, and the reason we've set up a clinic in the needle exchange and at Auckland Opioid Substitution Treatment Centre is to treat people with active infection who are still injecting. Because if you're going to eliminate hep C, you have to treat the people who are transmitting the infection. And there's a real push now to treat the young injectors, the people who are still spreading the infection, to turn off the tap, so to speak. And so that's not a contraindication. A very big study, in fact there have been several now, have looked at treating people who are still injecting and have shown that their cure rates are the same. Your question is, well, what about the high reinfection rate if they continue to share needles? In fact, it's quite a very low reinfection rate. It does occur, but we're finding that most people who engage and go on to this new oral treatment actually also engage with harm reduction strategies.
I just think we've packed into the last hour and a quarter the most amazing amount of information. An enormous gratitude to Ed for spending his night with us tonight. Thank you all for staying with us. It's been a fantastic review of the current situation, and I would just encourage us as primary care providers to sit back and to look at how we are going to manage this over the next 12 months in each of our practices, with upskilling of staff and working in partnership with our pharmacist colleagues. So thank you very much, Ed.
Okay, thanks Diane, for the opportunity.
Thank you all for coming and sharing our time with us tonight.